definitely they will see one of these cases in their practice. We thank you once again for IIT Tamil Nadu branch for giving us this opportunity, especially to Dr. Rajendran for continuing and persevering in bringing this to the thing. Hand over the mic to the moderators and to the student to start the topic.
Thank you, madam. Am I audible?
Yes, sir.
Okay,
Yes,
thank you, ma'am. Shall we start, sir?
Yeah, start, madam. Start.
Okay, Rajkamal, please start.
Okay. Good evening to all. I am Dr. Raj Kamal, third year pediatric student from Institute of Children and Hospital for Children, ECMO. Today I am presenting is the history part dealt by me and the examination part subsequently dealt by my colleague Dr. Arunjiva. 83 days old male child Sriharan, firstborn of a non-consanguineous marriage brought by the mother from Orakanadu, whose reliability is good, with the complaints of yellowish discoloration of eyes from day 20 of life. Prolonged bleeding from the injection site, incessant cry for duration of 1 day, not gaining adequate weight. Since the insult would have occurred antenatally, I would like to present the case from the antenatal. Antenatal history: first trimester, married at the age of 26 years. She was conceived after 1.5 years. Pregnancy confirmed by UPT. Pregnancy and booked and immunized case at Orakanadu PHC. Preconception weight was 43 kg. Total weight gain during pregnancy 12 kg. No history of previous abortion. No history of fever with rash or post-auricular swelling or joint pain or genital vesicles. No history of any drug intake. No history of any ionizing radiation. First trimester scan was normal. Second trimester, able to feel fetal movements, iron folic acid tablets taken and TD injections are given. She was diagnosed to have GDM after 20 weeks of gestation and she was on insulin treatment. No history of hypothyroidism or pregnancy-induced hypertension. Second trimester scan was normal. No history of chronic debilitating illness complicating pregnancy. Third trimester, able to feel fetal movements. Third trimester scan was normal. No history of antepartum hemorrhage. No history of fever, forced milling discharge. Natal history, date given on 21/9/20.
The antenatal history was not contributory.
Ma'am?
The antenatal history is not contributory. Are you able to hear me?
Yes, ma'am. Yes, ma'am.
So the antenatal history is not contributory for your diagnosis.
Yes, ma'am. Antenatal history, it was normal, ma'am. No history of fever with rash, no history of post-auricular swelling, no history suggestive of torch infection.
Continue.
Okay.
Do you think that is complete, your antenatal history? Because we may not be able to come to that. This is a very specific case which you already have given a title for that. For that thing, have you asked the specific antenatal history? Do you think you have asked?
Ma'am?
What is the title of your case? You're starting the case with a child of, you're saying it's going to present an infant with neonatal cholestasis. That's what you said.
Yes, ma'am. Yes, ma'am.
Have you asked specifically for that complaint? Have you asked anything, or this is general antenatal?
Illa, ma'am. I have asked specific for related to the neonatal cholestasis.
What do you think is in my mind?
Ma'am, with the view of torch infections, I have asked for fever, rash, post-auricular swelling.
Okay, I think maybe you might not know what you should ask for is itching during pregnancy. Intrahepatic cholestasis of pregnancy is very important because babies born to those mothers can get bile salt transport defects which can present as cholestasis in the newborn.
Okay, ma'am.
So that I think is what we would have asked you to think. Second one is we will be asking you that may not be there, but acute fatty liver of pregnancy that you've not given a proper history. But at least ICP should be mentioned because that is what is now. Because later, if you say the diagnosis is PFIC, then we will ask you, did you ask for itching? Do you think, Nirmala, that was what you also wanted, no?
Extra eyes.
That is what I think she also wanted. That specifically, that is what you all should all learn. General questions, you all are very good. You'll keep on rattling. For that child, what is the antenatal history they will want you to know? For this baby, what is the specific antenatal history we want you to say? That is very, very important. Here you said torch infection, but now That torch itself is gone. Very few. We keep on talking about torch, but where torch? Torch is not important. Other things have started coming. So the other thing, main thing here is ICP. That is what they will be waiting for. Okay.
Okay. Thank you.
Hmm.
Natal history date given on 21/9/20 while she was going for regular antenatal visit and 16/18 in Tanjore Medical College. Obstetricians told that her amniotic fluid was decreased with reduced fetal movements. So emergency LSDS was done. Baby was born at 35 weeks, birth weight 1.2 kg, cried at birth. Baby was admitted in NICU for very low birth weight care. Initially, the child on O2 support for respiratory distress, subsequently weaned off. Initially, the child was on IV fluids and gradually changed to tube feeds. While changed to tube feeds, the child developed abdomen distension and skin abscess in left forearm, which was treated with IV medication. No history of delay in passage of meconium, no history of neonatal seizures. From 15th day, baby was with the mother for Gangaru mother care. The mother noticed the jaundice in the eyes, which was said to be normal in the hospital. The baby gained the weight gradually. Baby was discharged on 13th day. Discharge weight was 1.6 kg, ma'am.
Is it enough?
History of presenting.
Dr. Rajkamal, what is the importance of taking natal
Yes, ma'am.
history in this child? Natal history?
Ma'am?
Pertaining to neonatal cholestasis, what is the importance of natal history?
Ma'am, to differentiate between the biliary atresia and neonatal hepatitis. Ma'am, in neonatal hepatitis, child will born with preterm babies, IUGR babies, ma'am.
Is that alone? So whether it's a term child, so you say preterm, IUGR, and asphyxia is also very important. How asphyxia can cause cholestasis. Suppose you get asphyxia babies, they call you for a call over with direct bilirubin. How that is important? See, asphyxia babies also can go for ischemic hepatitis. They can go for cholestasis.
Yes.
Severe asphyxia babies, suppose
Okay.
not able to take anything orally. Suppose in a neonatal ICU care with the now with the advent of all these things, they are giving TPN. TPN can cause cholestasis. All those things are very important.
Okay.
And your feeding history. See, child is given to the mother soon after delivery for breastfeeding. How feeding is
Yes, ma'am.
important in your cholestatic jaundice? Can
Yes,
you
ma'am.
answer? As a pediatrician, a
Ma'am,
child.
history of feeding.
Yeah. How feeding is important as a pediatric resident or even a pediatrician, primary care physician taking care of a child.
History of
So few things.
feeding difficult.
Yeah. A child who is able to suck at the breast indicates child is otherwise well. Not able to suck, it can be a sick child with cholestasis or some of the differential diagnosis. Second, as said, TPN can cause cholestasis, and galactosemia is one condition where you have to exclude breast milk from the baby. So feeding indirectly gives the sickness of a child, the well-being of a child, and some of the metabolic conditions where you cannot give breastfeeding as a feed. And third, also a TPN-related cholestasis. So that indirectly gives a natal history is very important in dealing a child with cholestasis. Yes, proceed.
No, Rajkamal, you know that the natal history, sorry, go back to your natal history. You're giving so much of details in that natal history. Go back. The mother
ma'am.
had less amniotic fluid.
Yes, ma'am.
What are the significance in GI when you have less amniotic? Just mention two. Anything you say, the examiner is going to ask you. You cannot just say that and say this is not connected. You have given so many points. Go to your natal amniotic fluid. What was it?
Oligohydramnios, causes for oligohydramnios.
So what? Just give us 2 points in GI.
Ma'am, due to any renal anomalies, ma'am.
GI.
GI. Common.
Mainly renal. Good. But anything else?
You put in NG tubes sometimes.
You said you put the NG tube and it went through also. See, what you all always do as students, You prepare only for that case and come. Remember, the examiner will never ask about that case. You have given so many positive. Can we just rush through all this without the child has developed distension, skin abscess in left forearm, treated with medications? How many babies
ma'am.
come with so much of problem in that? When you have this type of history, will you think of biliary atresia or will you not think of biliary atresia? Classical biliary atresia.
I would
Huh?
not think of biliary
You will
atresia,
not
ma'am.
think. Then what will you think of with this type of presentation? 1.2 kilos with so much of infection and all that.
Ma'am, one is sepsis, ma'am. Sepsis as a
Very
cause
good.
for.
Sepsis. So you're thinking of sepsis. So you're thinking of sepsis. Very good. So that's very important. So is sepsis a cause of neonatal cholestasis?
Okay, ma'am.
Is sepsis a cause?
Ma'am?
Is sepsis a cause of
And
neonatal
cause
cholestasis?
for
Yes, ma'am.
It can be a cause.
It
So
can
that
be,
is you're trying to keep that in your mind. So that is very, very important. So you're giving a very important history that the baby is having a sick baby who's having abscess
Yes, ma'am.
treated with IV medications even as soon as it is born. And
Yes,
then
ma'am.
it develops all this. Okay, now you go.
History of presenting illness. After discharge from the hospital, mother noticed persisting discharge, which was non-progressive, that was associated with deep staining of diapers. As per mother history, child passing yellow-colored stools in some days, and in some days it was clay-colored stools.
why you are mentioning deep staining of the diapers? What does it indicate? What do you mean by deep
It
staining?
indicates cholestatic jaundice, ma'am.
Deep staining, what
It
color?
indicates
Deep yellow, you mean?
deep yellow.
Hello?
Why the diaper is stained?
Ma'am, it
Why-
indicates
No.
conjugated bilirubin in the urine, ma'am. So that's why there is deep staining of diapers.
The conjugate bilirubin is water soluble.
Yes,
Okay.
ma'am. It's also it's excreted in the urine.
So that is
Only
all
bile pigments. So just the bile pigments and urobilinogen, that's all. No, not conjugated. You don't call conjugated in the urine.
Okay.
Yes, ma'am.
And it is
So
always
terminologies, be very careful. Don't get
Okay.
scared. You just
Okay.
say there's nothing here, but conjugated is always in the blood.
Blood.
Okay.
Okay, ma'am. Okay, ma'am.
Okay.
Okay.
With this history, does it look like neonatal with biliary atresia?
Ma'am,
With this history, does it look more like intrahepatic or like extrahepatic?
intra like hepatic, ma'am. More like intrahepatic.
Tell the PG. See, we know the answer. You tell why.
From the starting from the natal history, child was born with a preterm, very low birth weight child.
Very good.
And then history of NICU admission for a duration of a total duration of 30 days.
Yes.
Then the history of abscess was there. History of sepsis was treated with IV medications.
Okay. Just say one word. It was a sick baby from the beginning.
Sick baby.
And now
Yes,
it is presenting with features of cholestasis
cholestasis.
as evidenced by jaundice, eye-colored urine, and yellow-colored stool. A pigmented stool for some days is unlikely. You cannot say definitely not. Unlikely to be biliary atresia. When will in biliary atresia stool be yellow color?
After sometimes the outer layer may be pigmented.
Very important. Outer. That is
due to the intestinal secretions, ma'am.
Continue.
Yes, ma'am. History of abdomen distension for duration of 45 days. Started after 35 days of life. Insidious in onset and progressive. More in the upper abdomen, not associated with the facial puffiness, breathlessness, or presacral edema. History of
If a baby with 45 days comes with abdominal distension, what will you think of? What other history will you ask?
Ma'am?
Abdominal distension, what are the conditions you will think of? 45 days old baby comes with abdominal distension. Jaundice may or may not be there.
Okay, ma'am.
How will you, what will you come in your mind?
Ma'am,
This
whether
child you said more in the upper abdomen. Upper
yes,
abdomen
ma'am.
generally in infants is very difficult, especially newborn, very difficult to differentiate between upper abdomen and lower abdomen. Whenever
Okay,
there is
ma'am.
abdominal distension, usually more or less it's uniform. So when
Okay,
child of 45 days old comes with abdominal distension, what else will you want to ask? Leave this other, what else will you think of?
ma'am, sepsis
Okay, sepsis, why there is abdominal distension sepsis?
due to the bowel ischemia.
No, think of common things. Why generally, what do you see? Why the abdomen distended in infants?
Politically, yes, ma'am.
So it's due to an ileus. Okay,
Yes,
then
ma'am.
what are the causes? So what are the history you'll ask?
Ma'am, it's uniform distended or not, whether the child with a uniform distension, is the child have any features of any cardiac failure like CCS?
No, only fluid is the only cause for abdominal distension, is it?
No, ma'am.
Then what else can cause abdominal distension?
Fat, fluid,
Fat, leave, it's a newborn, no fat.
feces, any constipation history, ma'am. History of constipation.
Constipation and what else?
Yes, ma'am. History of constipation, ma'am.
What
Hitchcock
else will
disease,
have?
abdomen
In
distended.
addition, cause what else the child will have?
Delayed passage of meconium.
The
Ma'am?
child will vomit, no? If you're thinking of an intestinal obstruction, the
Yes,
child
ma'am.
will vomit.
Due to the intestinal malrotation. Intestinal malrotation, ma'am.
Okay, so this child did not have any vomiting or constipation. That's what you mean, no?
Yes, ma'am. No history of vomiting, constipation.
So what do you think this abdominal distension is due to? Previous slide, please.
More or like any organomegaly, ma'am.
So why do you think it's organomegaly?
It's not associated with any facial puffiness and more in the upper abdomen, not associated with facial puffiness, breathlessness or presacral edema, ma'am.
Did the patient complain that the abdomen distension is more in the upper abdomen? The mother
Yes, ma'am.
complained? Or you found it
Yes,
or the
ma'am.
mother complained? Hello?
Mother only told, ma'am.
Sumati?
Yeah. So you should tell that the mother said like that. Better you say that the mother noticed while
Yes, ma'am.
giving the bath or when touching the things that she's noticed swelling this side, that side. If you say it will become more, you're giving a very good history. What is that cause
Okay.
for that incessant cry, doctor?
Ma'am. History of
Possible
incessant.
causes.
Huh?
Possible causes. What are the causes? Could
For
be in
incessant cry in this baby.
this
Babies
baby.
will cry. In this baby, give me only one cause.
Ma'am, intracranial bleed, ma'am, hemorrhage.
Very good. So I think you can become pediatric gastroenterologist. This you should never forget. Because
Okay.
if you don't think about that and then you say colic and then you say ear pain and all that, you think. So it's definitely IC hemorrhage. Other causes you can always think about. But the most important cause of incessant cry is one day. What gave you the clue that this is this will be IC hemorrhage?
Ma'am,
What gave you the clue?
AF bulge, ma'am.
That don't know. What gave you the clue? In the next line, you're saying something else.
Yes, ma'am. History of excessive bleeding from the injection site for 1 day.
So two things you were getting, and
Yes,
what
ma'am.
should you tell? In neonatal cholestasis syndrome, vitamin K deficiency is very common. In which, in intrahepatic, is vitamin K deficiency more common, or in extrahepatic biliary atresia it's more common?
Biliary atresia, ma'am.
No. Usually the
Okay.
presentation,
Sorry,
whenever
ma'am.
you get IC
Sorry, ma'am.
hemorrhage, I don't know whether Dr. Nirmala, all our cases have been intrahepatic only.
Okay,
Very rarely you get an IC hemorrhage in a biliary atresia, something very unusual. So if you go and look at all the records in Institute of Child Health, you will find neonatal cholestasis IC hemorrhage has been only for intrahepatic. It could have been either for one of the infections or it will be for a very important metabolic, which is the metabolic cause which presents with persistent prolonged prothrombin time.
Neonatal homochromatosis, ma'am.
How many have you seen here? Which is more important than that? That line itself is mentioned in Nelson. Persistent prolongation of prothrombin time. Tyrosinemia.
Tyrosinemia, metabolic disorder.
Tyrosinemia is the one which is thick. Okay.
Okay.
Then next one. So each line, Rajkamal, you're giving a very good thing. So when you go back also, you must look at every line, why you're saying that.
Okay.
Why each line and why is that important? Okay.
Okay.
Why did they give? Injection was probably immunization. Okay. Then
Okay.
Rajkamal,
why
one
was
minute.
that vomiting? What is that vomiting important in neonatal cholestasis?
To indicate metabolic disorders, ma'am.
Give
Persistent
one,
vomiting.
see, you should not say metabolic, then give one answer. One, what is
Okay.
it?
Ma'am,
What is it?
galactosemia,
Anything,
tyrosinemia.
anything. You only galactosemia is the most, that persistent vomiting. Dr. Nirmala has also asked you, either it is a structural cause or it is a metabolic cause. Only these two. What is the other cause which can be there? If the child has been sick, is going for sepsis, what is the other one where they can have vomiting, which is treatable neonatal cholestasis? UTI.
UTI, yes, ma'am.
Urinary tract infection, they may not have fever. It is why this is important is it's a treatable cause of neonatal cholestasis. So I think if you can say galactosemia as one cause, then you can give one cause for your inter thing, and then you give UTIs. Okay, then
Okay.
An incessant cry, 1 minute. Your incessant cry in a 3-month or 4-month-old child after 16 weeks, that is after 4 months, can be due to pruritus.
Yes,
There
ma'am.
is irritability, poor feeding, crying due to itching. That's also because
Yes,
this child is only 45 days old, but later days to keep that
Yes,
also.
when does the itching start, Rajkamal?
ma'am, after 6
6
6
months.
months.
Why that hand to mouth, all that movement should start, no?
Coordination.
But before that, like Dr. Sumati was starting, itching may be there. So how they will be doing is they'll be crying, they'll be rubbing their legs, especially cholesterol potunda, charran
Okay,
சேர்த்து
ma'am.
they'll get all the infection, ulcerations there. Okay. Then go to the next one.
The
Proceed,
previous
proceed.
slide. Previous slide.
Okay, ma'am.
After excessive bleeding,
History of excessive bleeding from the injection site for the 1 day. History of ma'am.
okay, continue.
History of inadequate weight gain. No history of fever. No history of persistent vomiting.
What do you mean by inadequate weight gain? What did the mother say? Or you measured? It was measured, or you saw the
Mother's say from
flow chart?
mother's words. Mother's words, ma'am. I flow chart in later slides, ma'am.
Okay.
No history of fever.
What
No
are the
history of
causes for inadequate weight gain?
ma'am, inadequate weight gain in cholestatic jaundice, usually due to intrahepatic neonatal hepatitis, ma'am.
Why? What are the possible causes?
Due to the there is a deficiency of fat soluble vitamins, ma'am. Vitamin A, D, K, ma'am.
Okay.
And as the fat malabsorption, ma'am. Due to the deficiency of bile salt, the fats cannot be absorbed directly into the bloodstream.
How can you explain then biliary atresia? They are well preserved, they weigh normally. So when does the child have failure to thrive in all your neonatal cholestasis? When is it? IU infection, they'll be failure to not gaining weight. Chromosomal, they may not be gaining weight. Some metabolic if you're on the wrong diet. Most important is cystic fibrosis. That
Okay,
means there should be little more of malabsorption or calipod, not ADEK alone. Understand?
okay, okay, ma'am.
ADEK and then the fat comes a little later. So biliary atresia babies, you would have seen most of them are so well, they go for the immunization and they say, don't worry, weight is so good, everything is all right. So there is some other factor should be there in addition. And so most of the failure to thrive NCS is only cystic fibrosis. Many things, IU infection, cystic fibrosis, neonatal hepatitis, like you said, you were saying that chromosomal disorders, those are the ones which are very small, some genetic mutations when they are very small. Any other thing, Sumati, I think that's what we see, inadequate weight gain.
Most common thing, yeah.
Ma'am?
Yes, you proceed.
Inadequate weight gain generally points more towards medical disorders rather than the surgical disorders.
That's what they say. Yes.
Next, proceed.
No history of hematemesis, no history of seizures, no history of constipation, no history of feed intolerance, no history of crying during maturation, no history of passing oily bulky stools, no history of recurrent respiratory tract infection.
Why is seizures important?
Ma'am?
Apart from IC bleed,
Ma'am,
seizures.
hypoglycemia, ma'am.
So you said one cause being an intracranial bleed is one important thing. Hypoglycemia due to galactosemia,
Yes,
tyrosine
ma'am.
they can present with seizures. So some of the conditions where seizures are very important in cholestasis.
Okay.
Okay, yeah.
Okay.
Hematemesis? Cause for what could be cause for hematemesis?
Ma'am, it can be due to later on later will the presentation will be maybe the decompensated liver disease, or initially it can be due to any vitamin K deficiency, ma'am.
Coagulopathy, you mean?
Coagulopathy, ma'am.
In a it's an older child, then you'll think of portal hypertension and varicose.
Yes,
That's what you mean.
Yes, ma'am.
What is the significance of constipation?
To rule out hypothyroidism, ma'am.
Only that?
Anything else?
Anything else? Madam also said cystic fibrosis, they can have constipation. Down
Yes,
syndrome.
ma'am.
Down syndrome is also one of the causes for your trisomy.
Okay,
20
ma'am.
can have cholestasis. So these
Okay.
are things we should think when a child has got constipation apart from hypothyroidism.
Okay, ma'am. For the above complaints, child admitted in Tanjore Medical College, the incessant cry was settled in one day. For the bleeding, child was transfused with frustration plasma 2 times and PRBC 1 time. No further drop in sensorium or bleeding manifestation. Child improved and then child referred to ICH for further evaluation.
Yes, proceed.
Developmental history, social smile not attained, able to fix and follow the light. Child was exclusively breastfed, no sugar water given. Family history, non-consanguineous marriage, no history of abortion, no history of any similar illness in the family members. Immunization history, only BCG vaccination was given. Contact history, no history of contact with the TB or COVID-19. 83 days old child, preterm, very low birth weight child, history of NICU admission for the duration of 30 days, persisting cholestic jaundice, as evidenced by high colored urine and intermittent pale stools from day 20 of life, failure to thrive with the complications of bleeding tendency, upper abdominal distension, suggestive of organomegaly. I would like to discuss the case as a sick child, preterm, very low birth weight, cholestatic jaundice, not gaining adequate weight, increased bleeding tendency, more probably due to neonatal hepatitis. My DDs are the torch infection, metabolic, can be due to sepsis. And since the mother is not confident about the stool color, a rare possibility of biliary atresia with embryonic consent can be considered.
Among the neonatal hepatitis, which would you like to consider first? Starch, metabolic sepsis. Which would you like to put number 1, number 2, number 3? Based on the history, you get a clue you got from their history, from the mother.
Torch infection, ma'am.
Any pointers to pointing towards starch?
Preterm, low birth weight.
Is it alone enough?
The baby had some abscess and all.
Yes, ma'am.
So which would you consider first?
Sepsis, ma'am.
Because there is some improvement.
Yes, ma'am.
The baby. So
Yes,
because
ma'am.
there is an obvious cause of abscess in the baby causing cholestasis, coagulopathy, IC bleed. I would like to consider sepsis as the first possibility, followed by other conditions. Okay.
Okay, ma'am.
This doctor, first we would like you to say, now usually neonatal cholestasis you divide it into 2 big headings, no?
Yes, ma'am. Sick child,
hepatocellular or obstructive.
Yes,
So or intrahepatic, because now biliary atresia we think it is both intrahepatic and extrahepatic. We don't want you to say intrahepatic, but I think your Nelson also prefers you to say the hepatocellular causes. Under that, first is IU infection. Don't put neonatal hepatitis because that terminology they do not want to put as a. Earlier we were giving this big basket of diagnosis. Say IU infection or postnatal infection. That would be a good way of saying. Second
Okay.
heading, you want to say metabolic. That is all.
Yes, ma'am.
You
Yes,
do
ma'am.
not want to think of TPN related. You're not thinking of anatomical. You're not thinking of hypothyroid. You're not thinking of all that. You're not thinking. So only two you've got, mainly because that you have to say why you've already given the reason. So we would prefer you to say, that is, you've completely taken the examiner away from obstructive. You're
Yes,
not
ma'am.
thinking of biliary atresia. You're not
Yes, ma'am.
thinking of spontaneous perforation of the bile duct. You're not thinking of choledochal cyst. You're not
Yes.
thinking. So completely
Yes, ma'am.
you've taken away from obstructive. You've gone to hepatitis. So the heading will be, I'm thinking this is a neonatal cholestasis syndrome. So first
Okay.
line you must say that. For that itself
Okay.
you'll get marked.
Okay, ma'am.
Second, in that, what are you saying? Hepatocellular, because
Okay,
of the
ma'am.
yellow stool, small weight and thing. Under hepatocellular, what are you thinking? I'm thinking of IU infection, sepsis, or IU sepsis will be postnatal infection, then metabolic. And
Okay, ma'am.
after that, all the complications. Child has features of coagulopathy, or child
Yes,
has
ma'am.
features of failure to thrive, that will be that. So it will come
Okay.
like that, just like you say rheumatoid. So now you say, repeat it now. Neonatal cholestasis syndrome, most likely hepatocellular. Are you going to give biliary atresia again as a query?
Ma'am,
If I say no, this is biliary atresia, can you argue it out?
ma'am, it can be due to early embryonic onset, can be present with failure to thrive, ma'am.
But not such a thing. You'll never get a yellow stool. That's what you want to say. And by
Yes,
this
ma'am.
time, the baby would have become very sick.
Yes,
Suppose
ma'am.
I say this is HIV infection.
Okay.
What
Ma'am.
do you say? What is the argument?
Ma'am.
HIV. Suppose I say HIV. Can you argue it out?
Ma'am.
You
Is
want
it
to say yes
possible?
or no? Is it possible or no?
Yes, ma'am.
Can be. It can be, because
Yes, ma'am.
the acquired, you can have some immune deficiency, something is happening to the baby, you're not very sure, and we do not know. Earlier, when we were doing congenital syphilis, we had to tell, especially when babies were very sick. So we have to, can you say
Okay.
this is HLH?
Yes, ma'am.
You can.
Sick child. Sick child,
Child,
ma'am.
but it's
It
not
can
the
be.
presentation. That's what you have to say. But they don't present with
Okay.
abscess first, then the jaundice. So they're little
Yes,
more,
ma'am.
but all these you have to keep in mind, because sick
Okay.
neonatal cholestasis syndrome, there are only few conditions. One is sepsis, one is tyrosinemia, second is HLH, third is NH. That is all, neonatal hemochromatosis. Sick
Okay.
NCS. So sick
Okay.
NCS, there are treatable and metabolic. So in the treatable,
Okay.
you have your sick NCS is sepsis, and in the
Okay.
not treatable, or the other more complicated are these three. So that also should be kept in mind. If you give a very good differential diagnosis, you have more things to talk and discuss. If you give very small diagnosis, main reason you'll narrow the diagnosis because you know the answer. So you should go with an open mind, as if you don't know anything about the case. Then you will bring many things in the diagnosis. Remember, you have not yet
Okay, ma'am.
examined the baby. So
Okay.
you have to give more DD here. After you examine the baby, the DD will become small. So here you should say,
Okay.
in my mind, I would also like to think of other possibilities and give these few. Then only
Okay.
the examiner is very
Okay.
happy. Since the mother is not confident, rare possibility of deletesia, embryonic onset you have written. Okay. But I think that
Yes,
will not be so common, but you have just given that. Okay. So I would please put the word properly. Use that word neonatal cholestasis syndrome. They still want that word. They still want
Okay.
that definition.
Okay.
NCS, even though it is there. So NCS, intrahepatic hepatocellular, then the etiology, then the complications. Okay.
Okay. Okay.
Yours is over. Yours is
Yes.
over.
Ma'am, examination will be
History over,
by
history over.
Dr. Arunji.
Anything you agree,
Yes,
no,
ma'am. History is
Nirmala, the
over.
diagnosis they should bring like
We
that?
should have put neonatal cholestasis syndrome and
Ma'am?
then brought the differentials, madam.
That's the way it should come,
That's
no?
it. Neural hepatitis is not a diagnosis nowadays.
So NCS, then
Near
come
course.
to your hepatocellular, then come to the etiology, then come to the complications.
Okay.
With the other one last
Complications.
you did.
Okay.
And
I
think
told
of
him
other
also, but
details.
still insists on neural hepatitis. I don't know why. I
He
told
liked it. Maybe he read our old notes.
oh, maybe.
We did teach
Okay.
all this, but that was when you were very young. Okay, good. Very nice, very good.
Okay.
We can call you back, no, when the other one is
You,
presenting.
Yes, ma'am.
please wait. We might ask you some more questions.
Okay, ma'am.
Okay, Arun, start. Slides. Share your slides.
Yes, ma'am. The slides are visible, ma'am.
Ah, yes, visible. Put this slideshow.
Good evening. Coming to the examination, on general examination, the baby is alert, express is present, there is no failure, no
Is a
sign of
sick child. Child was alert, huh? Sick child.
child is alert.
Okay.
Express is present, there is no failure, no cyanosis, no clubbing, no lymphadenopathy, and there is no sacral edema. Vital signs, the pulse rate was 130 beats per minute, regular in rhythm, normal in volume and character, felt equally in all cerebral pulses, no radio and radius interval delay. And the blood pressure is 80 per 50 millimeters of mercury measured in supine position. Respiratory rate is 36 breaths per minute, abdominal thoracic type of respiration. The temperature and saturation is normal. Anthropometry, the weight is 2.2 kilograms and the length is 46 centimeters and head circumference is 35 centimeters. On plotting these parameters in Fenton preterm growth chart for boys, all the three parameters, length, head circumference and the weight was below third centile.
What does it show? What does it show below third centile?
All the three parameters are below the third centile, ma'am. There is a failure to thrive.
Arun,
Okay.
is it alone enough? General examination, is it adequate?
No, he'll come, I think.
Okay.
On head to foot examination, anterior fontanel is open. It is about 4 cross 4 centimeters, flush with surface, and it is
What's the
pulsatile.
normal size of AF?
Ma'am, it's around 2 cross 2 centimeters, ma'am.
So when is the AF wide open? What are the causes?
Wide open in hypothyroidism, even preterm babies will be wide open, and Down syndrome. And the posterior fontanel is open, admitting the tip of the receive finger. There is no dysmorphic facies.
When does
No,
posterior frontal close?
it closes around 2 months of age, ma'am.
Suppose if delayed, what do you think of delayed closure posterior fontanel?
Hypothyroidism, and even in Down syndrome. There's no dysmorphic facies, no cataract, no ecchymosis of petechiae, no signs of vitamin deficiency, no signs of liver cell failure. The spine is normal. Mongolian spot is present in the trunk. Umbilical hernia is present. Bilateral test is palpable. Examination of the abdomen. The child was examined on the mother's lap. On inspection, abdomen is distended. Umbilical is normal in position. Umbilical hernia is present. There is no umbilical discharge. All quadrants of the abdomen move equally with respiration. No visible gastric or intestinal pulsations. Skin over the abdomen is normal. No scars and sinuses. There are no dilated veins on the abdominal wall. On palpation, superficial palpation, the abdomen is soft. There is no tenderness, no guarding and rigidity. On deep palpation, liver was palpable in the right hypochondrium, 3.5 centimeters below the right costal margin along the mid-clavicular line. And the surface was smooth with rounded margins and soft in consistency. Seeing was palpable in the left hypochondrium, 3.5 centimeters along the long axis, enlarging towards the right iliac fossa, and it is soft in consistency. On first session, the liver span was increased, was around 7 centimeters, and the plants are resonant. On auscultation, the bowel sounds are heard normally, no buoy over the liver. External genitalia, bilateral testis palpable, normal in size and position, and there is no scrotal edema. Coming to the stool and urine examination, the stools were pigmented and the urine was dark yellow in color. Other system examination, cardiovascular system, the first and second heart sounds were heard normally only in the apex on the left side. There is no murmur. Respiratory system, bilateral air entry equal, there are no added sounds. And central nervous system, the tone was normal. This is the case summary, 83 days old male child, with history of adult discoloration of eyes and urine, history of passing pale schools intermittently, history of incessant cries, and history of prolonged bleeding from the injection site. A preterm 35 weeker with birth weight 1.2 kilograms, with failure to thrive, with pigmented stools, expressed hepatosplenomegaly and microcephaly, with wide open AF and umbilical hernia. This is a case of prolonged cholestasis of infancy. And I would like to give differential diagnosis. First one being TARS, and the next is sepsis. The third one could be a metabolic cause. Finally, idiopathic pneumococcal hepatitis, and there will be coexistent congenital hypothyroidism.
Justify your diagnosis, differential diagnosis. What are the points given for each and every diagnosis?
TARS, because the preterm baby with failure to thrive, there is a hepatosplenomegaly with microcephaly and jaundice. So I would like to give the first differential diagnosis as TARS. And since preterm baby history of prolonged echo-admission with IV access and failure to thrive, the second differential diagnosis could be sepsis. And the third one is metabolic. I think there is failure to thrive with hepatosplenomegaly.
If it is metabolic, what are the conditions you are thinking?
Hyosmia, child with hepatosplenomegaly, with failure to thrive.
Either metabolic conditions where like a child can be sick, seizures,
Galactosemia.
Galactosemia.
Doctor, go back to your examination. We have not asked you any questions. You finished very calmly. Go to the first one, first slide. So that the PGs also will know that everything has been done well, no? So I think your examination, everything was very correct. But you know, this clubbing at this age, very rare to see. And then, so don't routinely say certain things unless you are very sure. 80 days, we don't see much of that. And most of these babies, when they're not very alert, you can say they are conscious or something like that, like Madam was saying. Alert and things. So I think that is very important. Go to the next slide. Be careful when you present. I think someone is asking that soft consent is not possible in such a condition. I think they were very correct before your vital conditions. Okay, good. The next one. Wait, okay. So there's something you're saying, trying to say that the baby is very small. So go to the next one. All this tells you probably there's an IU infection, something for a long time or a metabolic. Then this was all right. Here, I think she's asked you that no dysmorphic faces. Yes, you can say that, or very characteristic, you can say no features. You can definitely no features of Downs if you really want to say, because you were talking about that.
What
And,
dysmorphism do you expect in this?
And no signs of vitamin deficiency. Don't give it like that, because you have said I see hemorrhage, coagulopathy. You've already mentioned once. Just say there's no cirrhosis, no fractures noticed, and leave it like that. If you say no signs, they will again ask you what is the usual ecchymosis. What do you talk about? Blueberry muffins. So if you want to say blueberry muffins, some skin manifestations, you'd say that. When will you see cataract?
TARS infection.
Which dysmorphic faces? What give by Give 5 examples of dysmorphic facies.
Dysmorphic facies, Down syndrome.
Hmm.
Down syndrome will be having a flat occiput, round facies, mongoloid
Okay, you
snap.
know the facies, then leave it off. Second,
Second one, you can have in Alagiri syndrome, ma'am.
okay, you know the facies. Okay, third,
Zellweger syndrome.
very good. Four,
Hypothyroidism, ma'am. Coarse faces.
hypothyroidism. Then also any of the other chromosomal also you can have. So these are the facies. Okay, go to the next slide. No signs of liver cell failure. Don't say such things. Look at the palm. Say no palmar erythema, spine normal, Mongolian spot here, umbilical hernia you've spoken about, and existing. Okay, go to the next slide.
Then vitamin K deficiency coagulopathy is also manifestation of liver cell failure. So don't tell abruptly as madam.
Okay, no signs. Once you say that again, they will catch you. Don't say that. Okay.
Be
Because
specific. Be specific.
Yes.
what is when do you say liver cell failure? What are the types of liver cell failure?
Liver failure.
Liver failure. How do you classify liver failure? That is, liver failure can occur in a
Failure.
no, you call it, the word fulminant has gone, no? So it can occur in a normal liver, you call it acute liver failure. If it occurs in a known, unknown liver disease, which is not present early, you call it as acute and chronic liver failure. If it occurs in a known liver disease, you call it decompensated liver disease. So that's how you classify the failures. So here, we don't have features of liver cell failure. Please don't say that at all, okay? Because baby is coming to you with jaundice, it has coagulopathy, all the features are there. And if you do the prothrombin time, that is only going to tell you. So no, don't say no signs of liver failure. Umbilical hernia, if you have umbilical hernia, in cases of somewhere you wrote no pedal edema, no? You wrote, no? So suppose you have pedal edema in children with NCS, what are the conditions where you get edema of the feet in NCS?
Agony syndrome, ma'am.
Very good. All that you all know very well. Agenist syndrome is very good. It can get unilateral. So otherwise you don't get. Later on only you get. Next slide. Okay. Distended umbilicus normal in position. Umbilical hernia. No umbilical discharge. Okay. You want to say normal in position. Okay. Distension also you can say whether the upper part is more distended because the previous exam thing, the upper abdomen was distended. So the same way you can say the flanks look full, the upper abdomen is looking more distended. That also you can say here itself. Okay. Next slide. All quadrants, skin over, no skin over the abdomen normal, no dilated veins on the anterior wall. Then don't make it as a routine. No tenderness. Next slide. Abdomen, can it be soft in this slide when you're showing this type of a picture? You don't even have a place to put your hand to make it see whether it's soft. You got such a big liver, you got a spleen, and this is the where will it be soft? So you don't have to say it is soft. Will the liver be soft in consistency in this child? When will you have a soft liver?
Infection, CCS, infectious
It
hepatitis.
will never be a soft liver. Such a big firm liver, either it will be firm or firmish. It may not be hard, and because be very careful, a soft liver is usually seen in 3 conditions. Give a condition where the liver is soft.
Congestive cardiac failure.
Very good. Congestive. Do you think this child has a congestive cardiac failure?
No.
This is an intrahepatic liver disease, and you are saying that the liver disease is also maybe intrauterine infection. You are saying it could be metabolic. Can it be soft?
Metabolic.
Even if your hand tells you it's soft, if in your mind tells you it's soft, don't say soft. You will not be penalized if you say firmish, firm. Definitely it will not be a soft liver. So you have to be very careful like this. Smooth surface, rounded margin. Very rare you get a rounded margin in these type of livers. Either you will get one sharp or you'll get it round is more things. So you'll get it either nodular edge or you'll get it may be a firm, it may be sharp. Okay, you've seen that. I have not seen the child. So 3 point right costal margin along. Always give the vertical span. There's all this has gone below the right costal margin along the, you've written the vertical span. Next line.
Yes, ma'am. In the percussion, I have mentioned in the percussion, ma'am.
Okay, percussion. Okay, tell that. Go to that. Give the spleen palpable. The soft. What do you say, Nirmala? Soft.
Hello?
Soft in consistency. Soft liver.
Firm, it's a firm liver and
I
firm.
think both are wrong, no? Both, and very, very important, doctor. Rather than they'll just, penalize you only for that finding. Be very, very careful. You will not get it. This is chronic disease or is it an acute disease?
Sorry.
Chronic disease. It's so even though the baby is only 83 days old, you're counting days inside the uterus, no? So it becomes chronic. So all these are classified as chronic. So you'll never have a soft consistency. Next. So good you made all these mistakes so the students don't make this mistake in the exam. Next. Percussion, good. Liver splan, 7 centimeters. Where you should tell us. Flanks are resonant. Okay. Do you think this child will have little fluid in the abdomen or no? It may have some fluid, but what you're saying is you're not going to do the thing. You're not going to do puddle sign for this baby because the baby is sick. We don't expect you to do, but look at the umbilicus shining like that, pushed down, pushed out. Though you have organomegaly, I feel there may be a little fluid in the abdomen. And from here itself, some veins are seen which look little thing, but you're not able to see. Next slide. Auscultation, bowel sounds, no bruit of the liver, external genitalia, normal in size, no total edema. Okay. Next slide. I think there were some questions also on here. So the stool, oh, very good. Pigmented stool and dark urine. Very good. Very good. Showing that. Okay. So what does this definitely excludes the obstructive cause. So suppose you had a murmur, what all will you think of? Next slide.
Murmur could be due to congenital rubella syndrome.
Very good. Second.
Very registered with splenic malformation syndrome will have a VSD, the substance VSD.
Okay.
Alagille syndrome is the cerebral.
Downs and Alagille syndrome. Okay. CNS tone normal. Okay. Now you give the summing up. Show next slide. This you've already told us. So the yellowish discoloration that you told, now you give the exam finding, failure to thrive. So come here.
Slide, next slide. Next slide.
Yes, ma'am.
Yeah, next slide. Here only we want you to say IU infection. Again, please say neonatal cholestasis syndrome. I'm thinking of the hepatocellular type. I'm not thinking of obstructive. I would like to think of IU infection. None of these we are seeing nowadays. Toxoplasmosis we are not seeing much. Rubella we are not seeing much. Cytomegalo is so common. What we are seeing now a little more. We are seeing Coxsackie. We are seeing other viruses apart from this. So forget about this torch. Please don't use this terminology again and again. IU infection would be the best. Say IU infection, IU and postnatal. That's what you have to say. Put both separately. So first NCS for that hepatocellular infections, under infections, IU infection and postnatal. Metabolic, please don't expect the examiner to ask you again and again, what is that metabolic? Give 3 causes. What are the 3 causes? Tyrosinemia, tyrosinemia and NH you're thinking of. Okay, galactosemia, no vomiting, so unlikely to be, and no cataract. That's what you're saying, it cannot be. No? Anything else? So you're thinking more of tyrosinemia, a protein metabolic. Cystic fibrosis, we've been constantly telling you, cystic fibrosis is being missed nowadays. Failure to thrive, presenting at this age, please think of, they need not have respiratory, they need not have pneumonia, but that metabolic CF should be thought about. Then your neonatal hepatitis idiopathic, so that people don't want you to mention it at all. They don't want you to mention it as a differential at all. Don't give that anywhere. Just say IU infections, metabolic. Third, probably you can think of, I think this is all you will be able to say. Nothing much. So idiopathic and leave it like that. But that you need not mention. What do you say, doctor?
Yes.
Yes, madam. Madam, shall we take the questions, madam? They want answers for the questions.
Yeah, I think we can take that. There are some questions. Take that, doctor. Chat la vandirukku. You can start answering, doctor. We can now take one by one. Two எடுத்துக்கலாம். 14 are there.
Okay,
Maybe
madam.
you can start.
History of
Want me-
parental, history of total parental nutrition. That's important because parental nutrition can cause one of the causes for cholestasis, but prolonged parental nutrition is necessary to cause cholestasis, not a short duration. And this particular child is not on any parental nutrition, so that's why he's not mentioned anything about that parental nutrition. And as for meconium, you want to take meconium history?
No,
Yes,
no, you
ma'am.
take-
I mentioned it. Yes, ma'am. I have mentioned it.
Sumati, meconium history.
No, two are முடிச்சிருப்பா. You can finish up at least 3, then we can finish it fast. Finish 3 answers.
TPN, I think we have discussed, no? TPN
Finish
is
3.
TPN.
Finish 3 questions, Nirmala. Meconium history and umbilical sepsis varaikkum.
Meconium, I think meconium history he mentioned. There is no history of
Yes, ma'am. I have mentioned.
Oh, I think they want to know why the delay also. Umbilical sepsis reason.
Umbilical
Why
sepsis,
should you ask it?
umbilical sepsis, not specific. Any sepsis can cause cholestasis. Umbilical sepsis more in case of VHPO, it's a very important history. But umbilical sepsis per se need not lead to cholestasis. Can cause generalized sepsis and can lead to cholestasis.
Okay.
And why they asked?
Sumati, you can take the next 3.
Evidence of hypothyroidism. This child has got umbilical hernia, but cholestasis, but firm liver, spleen, failure to thrive, and all those things. We cannot say only the hypothyroidism as a cause. We have
Wide open AF and
open AF and PF. We have
open PF.
and umbilical hernia. These three
That's-
main hypothyroidism. So in your screening, you have to include even your thyroid profile. And small baby midline facial abnormalities, hyperpituitarism can present. They can have septo-optic dysplasia, where to do eye examination and also to look for genitals.
But
Then
they
if
present with hypoglycemia and other metabolic abnormalities rather than cholestasis.
adrenal insufficiency, hypoglycemia, shock. So when all the other features are present and some midline defect, then you keep that as a possibility. Possibility.
Clay stools generally favors the diagnosis. Yes, persistent clay stools always favors the diagnosis of biliary atresia. Even one pigmented stool rules out biliary atresia. So that's very most important history in cholestasis. The color of the stools.
This
The
style
most
is
important.
very bright yellow, so unlikely because it's not. And as madam said, clay colored, white colored, or even that is not dirty butter white. If it is
Or,
first,
dirty yellow.
the word is important. And why not primary immunodeficiency? So when to suspect primary immunodeficiency in a child? Apart from cholestasis, if a child has got multisystem involvement, recurrent respiratory infections, skin infections, then you can
multiple
think
sites infection and multi-recurrent infection.
then you can think of primary immunodeficiency. And if there is any family history, suppose there is a SIB history, all those things would is there. And single infection is very, very difficult to tell.
But I think someone has asked whether you can suspect SCID in this age. Actually, what happens is because of the transfer of immunoglobulins from the mother, most of these congenital immune deficiency, whoever's asked this question, is being missed. So if you have that in mind, all that you have to do is keep a baseline immune profile and then repeat it again after 5 months because of the history. So that type of baby will keep getting it. And again, repeated infections in the skin. And once you do it again after 5 months, you can document that, yes, definitely there's an immune deficiency. Otherwise, at this age, actually, we have also thought of this and we missed it because when you do it at this age, you get a lot of this maternal transfer of immunoglobulins and therefore it gets confused. That is the thing. Continue, Sumati.
Anthropometry. Yes, anthropometry is suggested of SAM only because all the parameters less than the third set. But generally, very young infants, you don't use the term SAM. We generally prefer to use the failure to thrive or failure to gain weight rather than using the diagnosis of SAM. And dysmorphic, I think you already mentioned, usually Downs and other trisomies, and Alagili and Zellweger's can be one of the causes for the dysmorphic with also with cholestasis. Next, Sumati.
Importance of examination fundus. Yes, fundus examination is very useful, but in a very young infant may be very difficult. We have to do under anesthesia. So fundus, IC bleed can be seen in a fundus. Then in case of your Niemann-Pick disease and even your where you get a big spleen with cholestasis, then you get what are the conditions? You get cherry red spot can be skin and eye infection, chorioretinitis,
Choroiditis.
IU infections, lipid storage disorders, and fundal bleeds. These three are important in a case of cholestasis where you have to look for the fundus, though it's practically very difficult unless done under anesthesia.
Soft liver, already madam has discussed that. Soft liver is not possible. Generally, it could be the firm liver because even in IU infection, because of chronic condition, generally it's only a firm liver rather than a soft liver. That madam has already discussed about that.
Should we mention extent of jaundice like we say in newborn? Here, once you say there is icterus, it is very difficult for us to say, but usually we look at the palm and the sole, but it is a deep icterus, so we don't, because there is so more findings here. In physiological jaundice, you will not have any finding in the abdomen. Liver and spleen will not be palpable. So you try to say the thing, that is how you're taught. So suppose you see the sole is also icteric, then you can say the level of bilirubin. Here it is a big thing. You have so many findings. So we just say icterus and deep icterus, and you can definitely say that the mouth, especially the mucosa above the palate and the mucosa, if it is pigmented, that indicates, especially in the cholestatic, you will get all the mucosa also, unlike in physiological jaundice where you don't have that mucosal pigmentation that high. Can we have all the quadrants of abdomen moving well with respiration, having such a large abdomen? Yes, it is very difficult.
Possible.
That is what I was trying to tell you also. Certain things don't present it routinely, like soft abdomen. Here, where is the softness? No one will ask you anything. You're saying there's a firm liver and the liver is so big, so the abdomen cannot be soft. So small things like this, you all should not make mistake. Continue, Nirmala. Tone, I think. Two
And
more
tone,
questions.
do we expect it to be normal? Depends on the cause. Maybe generally preterm and small for gestation, generally the tone is not normal. It cannot be
And
normal.
alpha-1 antitrypsin deficiency as a metabolic cause. Earlier, when we were students, we used to talk
Rare
about
in
that. But now there's a big study which has come from India. Out of 500 cases studied, and we have also looking up, there is no case of alpha-1 antitrypsin. We do not have that mutation. But now you find that people are getting married between countries, and you may get 1 or 2 cases somewhere when the genetic mutation comes as a sporadic. But as such, we do not have A180. But if you are going for an exam in UK, A180 will be the most common cause of metabolic cause of NCS. In our country, the most important metabolic causes are tyrosinemia, galactosemia,
Yeah.
bile salt transport defects, bile acid synthesis defect, and then cystic fibrosis. These are the 5 important metabolic causes of thing. After that, you have some more, which you will see as you think, like citrin deficiency and all that we are seeing. But the most important are these. We are not seeing much of alpha-1 antitrypsin deficiency, not seeing at all. I think these are the questions to Nirmala.
Yes, ma'am.
We can go to the investigation and come back, I think. There have some more presentation.
No, that's all. You have to ask them. He
Okay,
has a,
how, investigations, I think he has.
so what next?
Investigation. First, I would like to confirm the cholestasis by doing a total bilirubin and a direct bilirubin. And next, to confirm the severity of the liver disease, I would like to do a prothrombin times INR and serum albumin. And the liver enzyme.
CBC? You're not going to do a CBC? No.
You are not
Why you don't want CBC?
You can do CBC to look for
Any
sepsis.
abnormalities you'll find on CBC in this case.
Doctor always say CBC, whether you go for PhD, DM exam, whatever exam you go, please don't say you will get failed only for not saying CBC. Please take complete blood count always. This child has been sick. It has got a blood thing, has been admitted in the hospital. Counts may be high. You're thinking of so many things, no? Platelet may be low.
Yeah.
Please say CBC, even though LFT may because of the jaundice, but CBC should just come in your mouth. CBC, that's all. Don't miss that CBC at all. Whenever such a big spleen is also CBC. Okay. Tell all the things, what all can be there in this child's CBC. Give one, just give one cash thing about that. What will you think? What will be the count?
What is the
Hemoglobin.
CBC?
How much do you think the hemoglobin will be in this baby?
Preterm, already a there's history of transfusion also, ma'am, in the treatment course.
Just give one number, even if it's wrong. We're just wanting to
Don't
know
bother
what
about
number
transfusion.
you-
Just say if child comes like this, you do a CBC, what will you see?
Less than 10
Hemoglobin. Hemoglobin. What do you think the hemoglobin will be? The child is coming from a not a well-to-do family. They are coming a sick baby.
10, ma'am.
Okay, give 9 or 10. Okay, then TC. How do you think will it be?
Total count would be more than 10,000.
Okay, because some infection has occurred now. Also, some abscess has occurred, so it will be there, maybe there. Okay, platelet. What do you think?
Expect thrombocytopenia, ma'am.
Why? It could be even a thrombocytosis. So you should give both. Both you should answer. It may be a thrombocytosis as a reactive. I may be able to see sometimes. We don't see hypersplenism, low platelet, except if you have low platelet, what will you think of? IU infection.
IU
IU infection
infection.
per se can cause.
IU infection. Then your IU infection goes up. If you see thrombocytosis, sepsis goes up. So IU infections will become higher. You will get thrombocytopenia in your IU infection. Okay.
Then intracellular can also have a drop in hemoglobin. Child can just become very pale, apnea, seizures. So this child you cannot tell, no, maybe normal because child has got all features of coagulopathy, sepsis, all those things, and preterm baby. So I don't expect hemoglobin to be normal in this child. Okay.
Suppose the hemoglobin is 6 grams, doctor. Which infection will you think of?
Ma'am, I couldn't. Ma'am.
If the hemoglobin is 6 grams, this child, what all will go in your mind?
Congenital syphilis, ma'am.
What all?
Intravenous hemorrhage.
No. What infection? IU infection?
Congenital syphilis, ma'am.
Ada, எங்க காலத்துக்கு வந்து okay. Parvo B19.
Okay, ma'am.
Parvovirus.
Parvovirus. What is the other cause where you'll get such a low hemoglobin NCS in our country? Malaria.
Common.
Malaria.
Parvovirus.
Malaria is also there. Where else will you get a low hemoglobin? There is one more condition known as autoimmune idiopathic hemolytic neonatal cholestasis itself. What is that?
Ma'am, inspissated bile duct syndrome, ma'am.
There you'll get pale hemoglobin you want to get. Okay. So hemoglobin low. So it's very, very important to have that also. You should keep it in mind. What is the cause? So autoimmune diseases, what are the neonatal autoimmune diseases which can present like this? That's what we want you to know, whether they will present with low hemoglobin.
Gestational autoimmune levels.
Yes, you can have some neonatal hepatitis, neonatal autoimmune hepatitis, which can present, which are less common, but you should remember that also. Okay, keep going.
The liver enzymes, SGPT, SGOT, and
total bilirubin, total bilirubin.
Yes, ma'am.
What is that?
How do you expect this baby? Total bilirubin and direct.
Bilirubin will be more than 20% of the total bilirubin, ma'am.
Will you be surprised if you see some indirect in this child? Apart from direct, so there should definitely direct bilirubin to say it is cholestasis. Suppose you get both direct plus indirect. Are you surprised?
Hypothyroidism, if you're suspecting hypothyroidism, the child can have both conjugated and unconjugated bilirubin.
Okay.
Okay, proceed.
Coming to the next line of investigations, the liver enzymes SGPT, SGOT, and alkaline phosphatase with gamma glutamine.
So what will you expect SGOT, SGPT, and alkaline in this child?
From the neonatal hepatitis, comparing to alkaline phosphatase, SGPT and SGOT will be elevated.
Well, alkaline phosphatase is always elevated in infants and younger children. No? What is more important?
SGPT and OT will be more increased.
In this child, if the SGPT and SGOT is normal, will you be surprised?
If there is decompensation of the liver enzymes will be reduced.
No, in metabolic liver disease, the liver enzymes can be
Only
normal.
OTPT level in
OTPT
MS
can
or
be normal
cholestasis.
sometimes because there can be apoptosis. So it can be normal, but so you should not be surprised. Sometimes it can be the child may be very sick, but the enzymes may be normal. That is more suggestive of a metabolic liver disease. So what's the importance of gamma GT? What's the importance of gamma GT?
Gamma GT.
GGT will be elevated in most of the cases of neonatal cholestasis, except in P6 progressive familial intrahepatic cholestasis type 1 and 2 and disorders of primary bile acid synthesis.
How many prefix are there?
3 types, ma'am.
Huh? 6-side shape.
Advanced.
So six prefix are there. Only 3 is gamma GTP is elevated because your prefix 4 is also going to present at this age group. It is tight junction protein 2 defect, as well as your farnesoid X receptor is type 5, which also presents in the newborn and that age they are very sick, and the myopin. So there are prefix 6 types. I think you should just redraw the columns. You should need not know much, but at least you should know that it is increasing. As you are learning more, it is increasing. So how will you differentiate between bile acid, both of them, gamma GTP low, bile acid synthesis defect, and PFIC? How will you differentiate these two? Bile acid synthesis defect and bile salt transport defect.
Bile acids will be decreased, ma'am.
Where?
Bile acid synthesis defect.
Tell clearly.
Bile
Between
acids will be decreased in disorders of bile acid synthesis.
very good.
It is normal in P6.
It will be increased. In PFIC, it is increased, whereas it is normal in things. So bile acid is increased in PFIC. That is the answer. Okay. So SGPT, SGOT, you were able to say everything. Suppose SGOT is very high, they were asking you something. What is it? SGOT is higher than SGPT. More of metabolic. Then ferritin, alpha fetoprotein. Tell us where all will you get alpha fetoprotein high without HTC?
Without
Hepatocellular carcinoma.
Without tumors.
In only NCS. Only NCS.
Tyrosinemia. Tyrosinemia.
How much? So any neonatal cholestasis alpha elevated. But when do you suspect tyrosinemia? What would be the level to say?
It's in 50,000 lakhs, ma'am.
Okay, I think so far you've done. Then ferritin. Why did you do ferritin?
So, neonatal hemochromatosis and HLH.
Very good.
So, what is in your mind? Will you do this for all babies with neonatal cholestasis, or in your mind you will classify them and do the investigations, doctor?
Classify and do investigation.
How will you classify?
Based upon whether the baby is sick or well baby or sick.
You classified already 6, then pigmented, non-pigmented. So pigmented, you're coming to that order, no? In only pigmented, you will do all this. Don't go and do it. That's what we want to think. Don't waste your time doing everything. Suppose the stool is chalky white. Don't sit and do ferritin. Don't do all that. Understand? This is only because the stools has been pigmented and it's thick vein. Okay, continue. Ferritin, tell us the reason.
It will be increased in neonatal hemochromatosis, HLH.
Okay. Blood cultures, you will know. Torch profile, you know. Then, so far, you would have made some diagnosis, no? So most of the IU infections, you would have made the diagnosis by now. In your DD, first one was infection only, no? So IU infection, something you would have made, either chorioretinitis you would have got thrombocyte you would have made, you would have finished sepsis. So what is now left? Metabolic. So metabolic, what do you want to send first? Urine for metabolic screening, or you want to send one sample quickly for one test?
Reducing sugar.
Urine for?
Succinyl acetone.
Very good.
Reducing-
Succinyl acetone. Okay. If it is it 100% sensitive or not? Is it very specific or not specific?
Specific for
Very specific. So it's specific. So you're not sending it, and if it comes positive, can you say, oh, maybe it is not tyrosine? No, no, no. It is coming in the pathway. So definitely it is specific, and you will send it only when you suspect tyrosinemia. Don't go and send it in a baby who you're thinking biliary atresia. That is why that path we are asking you. You are taking this only when it is pigmented. Don't do for everyone. But why did you not talk about ultrasound in between this?
it's there one.
Next slide.
Why not before this? This you want to do after that metabolic screening, then do the ultrasound. We want to do ultrasound and thing. What will the ultrasound help you in this type of baby who is a sick baby who has pigmented stool? Will it help? Will it not help?
Helpful, ma'am.
What will it help?
Ma'am, the history of prolonged.
It will help only to exclude polydoctal cyst. It will exclude possible biliary atresia. So suppose you see a contracted BB here, then the diagnosis changes. So it will exclude those two, but it does not help you to make a diagnosis. So that's the answer you must tell us. So suppose the examiner asks you, why did you not tell ultrasound here? You can tell that. I want to make, so I'm sending this. While I'm sending, I will also send. This is not one after the other. I will be doing it parallel. Are you going to do one after the other? No, you are just saying you are
Simultaneous.
sending all this. I'm sending this and I'm also doing parallel. I'm doing the investigation. So you should not change your thoughts immediately. No, I will do. Just tell them like that. So now when you go and do a thyroid in this child, it is preferable to do because it's a treatable condition. But you must say, in this child, I will not think of just a simple hypothyroid. It is me. In addition, the child might have a hypothyroidism, but I will not blame this because it didn't have any of the features and it's a sick baby. Addition, whether this baby has hypothyroidism or not, I just want to exclude this is because it's a treatable condition. That's all you should say. Next, do you get such a big liver and spleen and all that in hypothyroidism?
No, ma'am.
No, you don't get. So it's not the classical hypothyroid. But in addition, suppose you get a TSH of 10, then you get flabbergasted. So, but you have to treat. So you are just doing it. Next slide. Blood test ella mudinjichilla Nirmala, over for him investigation. I think he's finished everything.
Yes, madam.
Sugar,
Yes, madam.
sugar, what you've said, you didn't say sugar.
Urine sugars also it is.
Urine, renal
What
function.
should you say? Urine sugar or non-reduced thing? What should you say?
Urine.
I think he's becoming tired. Sleep தூக்கம் வந்துச்சு. சொல்லுங்க.
Yes, ma'am.
Sugar இல்லாம போச்சு out. Sugar and please don't mention the creatinine. I had one baby who was actually neonatal cholestasis due to congenital adrenal hyperplasia, something else. So you see a hyperpigmented child, and if you have not done electrolytes, gone. So that child had hypoglycemia as the presentation, and it was actually a cortisol deficiency. So if you don't document a hypoglycemia at all and don't even talk about the sugar, you will miss 3 or 4 important conditions. What are the 3 you will miss? Galactosemia, you said, then?
Tyrosinemia.
That glucose will not come down. What else? cortisol deficiency, and then
Panhypopituitarism, ma'am.
yes, like that, something like that. And you've got even septo-optic dysplasia. Sometimes they can have this. So don't miss. How did you miss sugar here? Forgot. Electrolytes, forgot. Okay. Creatinine, forgot.
Renal is
Okay.
also very important. Some of the conditions, very good. Renal plus cholestasis. Just name one or two conditions. Renal involvement in cholestasis. Any condition?
Tyrosinemia, ma'am. Renal tubular Fanconi-like
Tyrosinemia,
syndrome.
galactosemia, and even allegedly can have renal involvement.
Yes,
Some
ma'am.
of the
Originally
conditions.
not this age. That's what the thing. But you must tell what it is. Okay.
Okay, yeah. And urine
Don't leave
metabolic
out
screen.
anything.
Next slide.
At last, rule out immediate VCR.
This side.
We like to do.
Previous slide.
Is IDA needed in this soil?
Not
You want to do IDA in this soil?
not necessary, ma'am.
When will you order for IDA?
Should not do.
Yeah. So when you have a
Fasting, how many?
pale yellow, then you can go for IDA. And what precautions you should take before doing IDA scintigraphy? What do you advise? Any drug you give before doing IDA?
Ma'am.
Not
Phenobarbital.
you have to try
And
phenobarbital for 3 to 5 days. But in this study has got dark pigmented stool. So IDA may not be
useful.
needed in this study.
Yes, ma'am.
Doctor, this HIDA, you say should not be done in this baby. Why? Because the stools are dark yellow. Okay. If they ask you, skip that HIDA. Ultrasound, you must say how many hours fasting?
4 hours of fasting, ma'am.
Huh?
Right.
At least 4 hours of 4 hours. 4 hours of fasting, ma'am.
What is
4 hours of milk feed only. You can give some plain water or something. The baby will be crying otherwise. Why?
Ma'am, gas will be contracted, ma'am.
So mainly to look at the gallbladder. Liver biopsy, you said, but why go for IUC? Are you going to do an open biopsy? Why don't you do a closed biopsy? See, routinely you all should not write down. You have already brought the baby into the pigmented stool, that type of neonatal cholestasis. You have excluded obstructive. Why open this baby's abdomen now?
No, it's not necessary.
You wrote it by mistake. IOC should not come there at all. This is a closed biopsy you will be doing. Would you want to open this baby?
No, ma'am.
Then why IOC for this baby? You will get a good bit even without thing. Just do this thing because see, that's why from the beginning we're saying, beginning itself, you tell the examiner, I am thinking of a baby with pigmented stools, a sick baby. I'm not thinking of obstructive. Re-emphasize that when you tell the investigation so that you're very clear. You're not going to do that. You're not going to open the abdomen. You're not going to send it to the surgeon. This is your case. This is a medical case. So you will do a liver biopsy and you will send the tissue for diagnosis. When you send the liver biopsy, where all do you think in this intrahepatic, which you said, it will be diagnostic? Will it help you or will it not help you? Only in what you have said. You've given some DD. Will it help? Will it not help?
It will be helpful in dark infections and metabolic.
That torch word itself, I think you all should remove it from your mind. IU infection in that.
Which infection?
which infection?
Which infection?
Avid toxoplasmosis, rubella, and cytomegalovirus.
No, with anything specific, doctor. Whenever you have a diagnostic, there should be something specific. You see this, you make a diagnosis. You're doing an invasive test.
What will you see in toxoplasmosis in liver biopsy?
Tissue biopsy can demonstrate tachyzoid.
Doctor, you just have to say the whole thing, doctor. Hepatocellular, feathery degeneration, inflammatory cells, giant cells. In CMV, I will see the inclusion bodies. Be very specific and say that. So for each one, like Dr. Nirmala is asking, mention each one in HSV what you can see. So you will see those inclusion. Then you make it out. Sepsis, you will not get much, but you may see micro abscesses. Second one, you said metabolic. Will you get any finding in metabolic? You will not get. Suppose you think of Alagille, then you may get. So certain conditions only you are going to get. So liver biopsy is mainly for you to say, yes, it is not biliary atresia, but also to find out all these causes, mainly for CMV, for if you have alpha-1T or in UK or somewhere, you make a diagnosis of A180. Alagille, you can make a diagnosis. NCAS, neonatal sclerosing cholangitis, you can make, but remove that IOC from there. Hearing screening, opthal evaluation, you will do after you make a diagnosis. So for tyrosinemia, by that time, if urine succinyl acetone has come high, what will you do for tyrosinemia?
Can you treat?
No, before that you must confirm the diagnosis. No, so you have to mention genetic studies before you do all this. Please mention that, especially when you come to metabolic. Say I will do exome studies, genetic exome, and confirm my diagnosis. I will also send the urine for screening. No, you can do the tyrosine levels in the urine, blood tyrosine levels. All that you should do. Just one test. You can't go and tell the parent, do you have this? So please do all that. Okay. You can send the urine for metabolic screening, and then you also do the exome studies and confirm the diagnosis. So you can definitely say in your exam, genetic studies should be done, and then I will do. So that is how you will go to that side of the thing. Then you go to now Dr. Subhati is asking you some questions. Tyrosinemia treatment.
Tyrosinemia. Can you treat?
Next one is treatable, ma'am. Nitisinone is given, ma'am.
Is it available?
Ma'am?
Is it available in our country?
No.
Not. Sure.
What is it actually, doctor? Nitisinone? Nitisinone?
Nitisinone.
Inhibits.
No, what is it actually? It is a pesticide used by the farmers. But when should you use to get good results? When should this nitisinone be given to the baby?
Before decompensation, ma'am.
Before as soon as possible. If you don't give it, then you will only lose the thing. As early as possible, and it should be taken lifelong. Otherwise, you have to go only for a liver transplant. The cost of liver transplant will be cheaper than the cost of NTBC.
In India.
In India. Okay, doctor, then they'll ask you, how are you going to manage this child? So how will you manage this child?
Supportive management. First, since the baby presents with history of prolonged bleeding, I would like to give vitamin K 5 milligram intravenous for the first 3 days and every 4 weeks.
That's enough. When they've come with the bleed, you may have to give FFP also, no? If they have already had a bleed, please give them FFP. If they've not had a bleed, it's okay. But otherwise, the bleed will continue. Vitamin K may not correct it immediately. So definitely, the prothrombin time will be prolonged. Then all the ADE, tell.
And to improve the nutrition, we can add a medium chain triglyceride oil to the breastfeed one.
What is the advantage? You are adding MCT.
And it's more water soluble. It does not require bile salts for absorption.
Does not require bile salt active lipase for absorption. Directly enters the water circulation. Okay. What is the natural source of MCT? Natural source. Any oil?
Coconut oil, ma'am.
What do you use now?
Coconut oil, ma'am. Coconut oil. Coconut oil, ma'am.
Yeah. When should you add the coconut oil? Before, after cooking, or before, while cooking?
Do you cook? You add and cook or after that? That's all.
Add and cook or After cooking.
After cooking, ma'am.
Oh, very good.
Very good.
We have given clue, madam.
Nobody has taken the clue.
Tired, yeah, 9, 10. Okay, go quick. So always classify. I will supportive medicine, medic diet. You have to talk about supportive water soluble vitamins, and then talk about the oil soluble vitamins. Then go to cholinergic agents. So have nice headings and then go. Okay, but all these are supportive. Specific therapy.
Ma'am, according to details, thoughts, intrauterine infections can manage
What are the drugs?
Be fast, be fast.
For toxoplasmosis, you can give sulfadiazine, pyrimethamine, and for cytomegalovirus, gancyclovir can be given, ma'am. And for herpes, neonatal herpes, acyclovir can be given.
Toxoplasmosis, any of the drugs? Pyrimethamine, can you give that? Anyway, go on.
Pyrimethamine for antiviral for the mother, ma'am.
No. Toxoplasmosis, any of the drug you have, apart from trimethoprim, sulfamethrin, any other drug you know? Okay. Okay.
If it's HIV, what will you treat?
Retroviral therapy with protease inhibitors and reverse transcriptase inhibitors, ma'am. NRT.
So what will you tell the patient? How will you follow up? What will you tell the patient? After all the investigation, you have no diagnosis. What will you tell the patient?
Well, I'll ask the patient to continue the
It can be
supplement.
even idiopathic, ma'am, up to 20%.
We'll ask the patient to continue supplements and we can
So this is where the genetic studies also help, because we do not know so many
Many
metabolic
conditions we are not able to diagnose.
So you will pick up something in the clinical exome. You have to write everything. And what other slide you've got, doctor?
That's all I think.
So that slide is very nice. That's not your NCS papa. No.
It's cured. That papa is cured, madam.
Cured papa. Very good. So you have more, I think, look at the questions, doctor. I think there are some questions in the.
Yes. Sumati, padu. Sumati?
I'm just scrolling the questions. Role of ultrasound cranium. What
We have to
should
do.
Should we start on
Ultrasound
antenatal history? Antenatal history.
Antenatal history. Should we start from antenatal history, discuss the presenting complaints? Yes, since a child has come in the immediate newborn period, better
From
start
birth.
with antenatal history as a past, because you get all the information starting from the maternal history, natal history, and immediate postnatal history is very, very important. So I think we have to start from the antenatal history for presenting this case as a presenting illness. How common is tris hydroxy coprostonic acid associated cholestasis? Very rare unless we look into that. I do not know, because we have never seen in ICH. Madam, any experience on that? Malti, madam.
What? How common is this hydroxyprostonic acid associated cholestasis? Very rare. So I think we have. That's why all these have to be looked at later. Unless you have some features, we don't think about that. So someone, I think they are who's listening is doing a lot of hepatology.
Study on that cases.
PFIC diagnosis of exclusion, no, because once you get a low GTP, you will go to that. If it is a high GTP, it look very much like biliary atresia. Your liver biopsy will definitely tell you PFIC1 will be bland cholestasis, PFIC2 will have giant hepatitis, low GTP, and your PFIC3 will be like biliary atresia, and it will have your IHC. You can do BSEP negative and MDR negative. So you can come. It's not a diagnosis of exclusion. should it be mentioned in differential diagnosis in such a case? No, you need not
Not in this
mention
case.
it. That's why we didn't bring it. We brought only the sick new metabolic in this condition. But for discussion, when people talk about GTP, we go into that. And I think the other one is with what specific
Can we classify investigation
role
group
of
as
ultrasound cranium? No, should this one they want gamma GTP and can we classify the investigations group test to find out liver function to assess? That's how you think in
that's
your
how
mind.
That's why I would-
That's what Nirmala is saying. Always to confirm the diagnosis, to investigate for the etiology, investigate for complications should be in your mind. That should be your theory-based answers also, and that is how you answer everything. But we should not give it as headings. So always confirm diagnosis. Whatever diagnosis you have said, give the confirmation test. Give the confirmation test for your complications, give your confirmation test for the etiology. Those will be your classification for the investigations. Gamma GTP and 5-nucleotidase. 5-nucleotidase is more theoretical. When we
they're not
ask you
gamma GTP?
biochemical test, you mention it, but we don't do it at all. Gamma GTP is used. Nirmala, you can take the rest, Nirmala.
Okay. Hepatocellular failure and intracranial hemorrhage in final diagnosis. As complications not included as intracranial hemorrhage is part of coagulopathy, and hepatocellular failure generally it's a biochemical diagnosis rather than a clinical diagnosis. So they have not because they didn't mention the values of INR and albumin. They didn't mention in the diagnosis. And serum ammonia, pyruvate, lactate. These are all depend when you suspect any inborn errors of metabolism. Then you will have to. It's all should be. You should not do for every other case. Only if you suspect some inborn errors, then you can do all this pyruvate, lactate, and urine ketones also. Urine
And for
ketones,
this, I think Nirmala, we should tell them that when there is sepsis or when the sick child, all these will be abnormal. No, Nirmala, that is why we don't do. And you have to repeat all this when the child becomes stable. All of you, please remember that most of these tests which we do for IEM will all be abnormal. Lactate will be high. Everything will be high. Your ammonia because it's sick baby. So if you think it is UCD, if you think it is organic acidemia, which is not the usual presentation like this, you must repeat it later on.
Urine, if you're able to document hypoglycemia, then urine ketones will be useful. Otherwise, generally we don't try to fast the child and take blood. We generally don't try to establish the fasting hypoglycemia. And role of ultrasound actually you have to do because we suspect ultrasound cranium is a must. Cardiac evaluation, vertebrae should be done only when you suspect alagili. That generally the alagili children, they are not the sick. They don't come under the sick variety. They come in the non-sick variety. And so when you suspect alagili, then you definitely will have to do a cardiac evaluation and the extreme vertebra. And alagili, there'll be the high gamma GT rather than a low gamma GT. And with what specific findings liver biopsy can we rule in or rule out the biliary atresia in case of neonatal hepatitis? You have to see in case of liver biopsy, if you've done it the right time, then definitely it can rule in or rule out liver biliary atresia. What you're trying to see is
like you say, tell me.
You have to look for bile ductal proliferation and bile lakes. And in addition, you have to see that portal fibrosis and portal edema, which is supposed to be more specific for biliary atresia. If you see all these things, then it favors biliary atresia. Whereas
Nirmala, I think we should tell them that per-operative liver biopsy is now recommended in the protocol for management of all cholestasis babies because it definitely helps us to avoid an open laparotomy. So only thing is you need a dedicated hepatopathologist to look into the slide. And this liver biopsy also, if you look at the ductal plate malformation, if it's present, it will tell you whether the Kasai will be successful or not. So a liver pre-operative liver biopsy is now the definite thing in the protocol. So must do pre-operative liver biopsy before you do, but you need a dedicated hepatopathologist for that.
Role of endoscopy per se in cholestatic infant may not be of useful. Maybe to find out any complications like portal hypertension, maybe it will be useful. But per se for a diagnosis in cholestasis, endoscopy is not a must.
And if on endoscopy,
Shall we wind up?
Yeah, we don't do endoscopy routinely, but on endoscopy, if you're doing for that any purpose, if you see bile, then it rules of biliary atresia, but the bile flow is always intermittent. So that may not exclude if the bile is not seen on endoscopy. That's one thing. Otherwise, routinely it's not recommended. Unless
Madam,
it's-
shall we wind up? Malti, madam.
Yes, doctor. So one more I think you have. Now we'll ask someone else the questions. They've not. Doctors, please wind up, or you have one more. Both the PGs who presented did very well. I just want you to just
We are having
comment
12
on
minutes more. You can continue up to.
antenatal diagnosis. Someone will ask you, Madam, can you not make an antenatal diagnosis of biliary atresia? Give me an answer. And what can you pick up antenatally in neonatal cholestasis babies?
Arun Jiva.
Antenatally, we can detect starch infections.
No,
Infertility.
what can you tell? This is like saying leptospirosis. Antenatal ultrasound, how can you pick up on the baby?
Situs inversus,
Okay,
any
so
polysphenia can be embryonic onset of biliary
you
atresia.
think of what? BASM. Biliary atresia.
Yes, ma'am. Biliary atresia with screening
What else?
malformation.
One more. Tell me something very nice.
Can
Polydoxis. And there is one more condition known as cystic malformations of the biliary atresia. Cystic type of biliary atresia.
Atresia.
That is supposed to be they present very much early and they can be picked up antenatally on ultrasound. So suppose by chance this baby was a biliary atresia baby and you sent the baby for Kasai. How will you say that the Kasai is successful, good or not good? What are the two parameters you check to say whether Kasai is successful or not?
Bilirubin normally it's the LFT following the procedure. Procedure.
Jaundice.
Passing pigmented stools. Passing pigmented stools.
Give me one clear. You must say something. You will do two parameters which will tell you Kasai is good, has been successful or not. Jaundice free or less than 2 milligrams 3 months after surgery. First point. Jaundice free or less than 2 milligrams 3 months after surgery. And you're going to test what is known as, what is that? What do you look for? What is that survival called? Native liver survival, NLS. Native liver survival, if it is more than 5 years, more than 10 years, that means Kasai has been successful. So the two parameters for checking are jaundice free or less than 2 milligrams 3 months after surgery and native liver survival more than 5 years. That is considered as good for Kasai. What are the others things? Suppose you have a baby who comes to you with neonatal cholestasis, they're done somewhere and has a scar in the abdomen. What are the causes of scar in the abdomen?
Intestinal malrotation, biliary atresia can be associated with it.
Polydoccal cyst may be there. Spontaneous perforation of the bile duct. How will you make a diagnosis in a male infant? Just clinical examination.
Billy scrotum. Billy scrotum.
Very good. Billy scrotum. Aspiration of ascitic fluid. How will you say it is biliary bile in the ascitic fluid? How will you say that it is
Biliary ascites. How will you diagnose?
What test you do in the ascitic fluid?
What will be present in ascitic fluid?
Bilirubin, ma'am.
How much should it be?
Compared with what?
Compared to the serum, if it's higher or more
Serum
than 6
bilirubin.
milligrams. What is the stool card test which is now being recommended? Is it useful, not useful? What is the sensitivity?
It is useful, ma'am. It is useful.
Tell 2 lines. We have 5 minutes more. Just tell what is it? Where was it first found out?
Taiwan, ma'am. In Taiwan, they have used it, ma'am.
Tell properly. Tell. It's a
In Taiwan, they have used it, ma'am. They have six colors, ma'am. Left and right. If they have the colors combined with the left, that is normal pigmented. That is, it is normal. That is right. That you have pale, light,
what is the specificity? What's the specificity? Quite high, 99. What is the advantage of this test? Suppose you put this in the birth card itself, birth certificate behind that card or behind the ration card. What will be the advantage in India?
Ma'am, it is yearly identification and yearly treatment of biliary atresia, ma'am.
They'll bring the
Yes.
babies earlier. So maybe earlier
Yes, ma'am.
detection of biliary atresia. Good.
Why earlier diagnosis is important?
Ma'am, even if you done within less than 2 months only, they will the chance of biliary the chance of bile storage and is good, ma'am. More than 80% will have bile flow if it is done within less than 2 months, ma'am.
80% bile flow. அப்ப எந்த surgery க்குப்பா? சரி. Very good.
Kasai
Anyway,
also interest me, ma'am. Kasai also
but
interest
it's
me.
not 80%. What thing is, even the 2 months, don't say 2 months. Say 60 days or
Days.
45 days.
Days,
We want you
days.
to treat in days, not a thing. But
Okay.
the flow is not 80%, doctor. It will, you will only get 45, 60%. That itself
Okay.
is good.
60%.
60%.
அவ்வளவுதான் 30 தான் answer. So you will not get 80. Anyway, at least you're answering loudly, you're answering. Very good. I think you're getting the energy. Any other questions, Sumati? Last one more. You can have one more round of questions.
I want ultrasound and biliary atresia. Just tell for the postgraduates. What do you see in ultrasound apart from the gallbladder? When do you suspect?
Other signs. You want the signs?
Triangular cord sign, ma'am.
What is triangular cord sign?
It's a cranial to the bifurcation of portal vein and anterior to the right portal vein. That is the area of echogenic fibrous tissue that is more than 4 mm is present. That is triangular cord sign is positive, ma'am.
Very good. And other findings, if the situs inversus, all in favor biliary atresia, but most important triangular cord sign done by a experienced sonologist, a very good probe. They can pick it up.
What is gallbladder ghost triad?
Gallbladder length less than 1.9 centimeter, ma'am. Irregular lining of the gallbladder and ma'am.
Very good. Very good.
Okay, continue.
Abnormal shape of the gallbladder, ma'am.
Very nice. So you got all. So you've got to give. Tell slowly. The PGs might not know, no. So you must tell all the answers slowly. Tell slowly.
Okay.
Good. I think you've got the. Nirmala, you can answer them. Ask them some more.
No, madam. I'll ask them.
So apart from vitamin deficiency, you have to correct even B complex. Recommended dosage, calcium, phosphorus, your vitamin, other things, iron. Okay, all those supplemented apart from your UDK and all your vitamin K, A, and D. And
now liver transplant. Which baby you will send for liver transplant in the intrahepatic? That is the hepatocellular causes. In the extrahepatic, only which one will you send? What are the 5 extrahepatic causes or the obstructive causes you talk about? What are the 5 obstructive? Biliary atresia.
Cholestasis.
What will be the percentage of biliary atresia? Suppose there are 100 babies with neonatal cholestasis. How many will be hepatocellular? How many will be obstructive?
Ma'am, obstructive will be around 30%, ma'am.
Oh, little more, up to 45. Okay, 30. Then that will be 70. So that is actually 65. 65, 35, 60, 40. That is the thing. Anyway, obstructive is lower. In obstructive, which is the most important?
Biliary atresia.
Biliary atresia. Second?
Cholestasis.
That will be only 3%. Third, inspissated bile duct syndrome. Fourth, spontaneous perforation of the bile duct. Fifth will be hairy cell leukemia and all that. In intrahepatic, which will be the highest?
Torch.
Why the word torch?
Intrauterine infection.
Just say infections. Under infections, you say intrauterine or you say thing. That will be, what will be the percentage? It will be 17 to 20%. Metabolic, 20%. What will be the percentage? Depends upon the center, 4 to 10%. And the others will keep coming down. So you know the percentage of all this, you should know. So if suppose it is, this is what? So which are the babies in this group who will go for liver transplant? One is failed, in obstructive, failed Kasai. That's all. Or late Kasai. That is, or late presentation of biliary atresia will have to go for liver transplant. In this, who all will go for transplant? Infections, will they go?
No, ma'am. No, ma'am. They will resolve.
Will metabolic, which will go? Tyrosinemia may go. PFIC, will it go?
Yes, ma'am.
Which PFIC?
PFIC type 3, ma'am.
Very good. Type 3 and 2. 2 also very high. 2, 3, 4. What about Alagil? Will you do?
It will have spontaneous resolvement. It will resolve.
Allergy is a spontaneous resolve. It's a genetic disease.
Okay, ma'am. Okay,
Some of them might survive, they can get married because they have a milder presentation because of the
Okay, ma'am.
system involved. No spontaneous
Okay.
resolvation is only for the idiopathic hepatitis.
Yes, ma'am.
அவ்வளவுதான் அதுக்கு வேற ஒண்ணுத்துக்குமே spontaneous கிடையாது. So no
Okay.
transplant. Allergy you may do depending upon the quality of life, even a thing. So PFIC also, suppose itching is very bad or they go in for end stage liver. In cholestatic syndromes, the indication for transplant is not end stage liver disease, doctor. It is quality of life. It is the pruritus, which is disturbing. All that itself will be an indication for transplant. So liver transplant, where will you get the donor? Live or this will be cadaver?
Live donor.
Live.
From whom?
Both.
From whom can you get?
Live donor.
From mother or father?
Ma'am, both. Ma'am, both.
Both you can take depending on what? Which will you do? Testing blood group or no?
Both.
Blood group
Ma'am,
is important or not important?
Not important, ma'am.
You can, why? That is most important, but now you can do with ABO incompatibility, but you must do so much of plasmapheresis, remove all the antibodies as far as possible, do group matching. If you don't, which segment will you take from the mother?
Segment 5, ma'am.
Yappa கஷ்டப்பட்டு
Amazing.
Said. So read little more of that. Father ten எடுப்பீங்க, mother ten எடுப்பீங்க. So கொஞ்சம் கடைசியில the examiner will want to laugh and smile, so they will ask you some questions like this. அம்மாட்ட எவ்வளவு எடுப்பீங்க, அப்பாட்ட எவ்வளவு எடுப்பீங்க, ரெண்டு பேர்ட்ட எவ்வளவு எடுப்பீங்க, all that they will ask. What is hepatocyte transplant? Where will it be used? In the metabolic level, you prefer doing a hepatocyte transplant. After all, you just need the enzyme. Otherwise, the liver is good, no?
Okay, ma'am.
So some of them they prefer, especially the liver disease like in UCD and certain things, they say why not do, especially Crigler-Najjar. Not that liver is okay. It is just that that enzyme is not there. So they feel why can't we do a hepatocyte transplant? So we read up little more of all this. I think we have brought it up to 9:30, no Nirmala?
Yes, madam. Successfully we have brought it to 9:30.
Dr. Rajendran?
Yeah, yes, sir. Yes, madam. Yes, madam.
I think we have given any questions, Pa?
Yeah, good. Madam, sir, Dr. Arun, sir. Yeah.
Any questions?
Hello?
Two questions left, I think.
If MRCP is normal, will GIDA be helpful in a 6-month child with persistent pale stool, madam?
No, MRCP, though it is very theoretically, it sounds very nice. You have to put the child under anesthesia. And lot of movement artifacts will be there if you don't completely sedate the baby. And MRCP, you can't put the baby separately alone into that huge chamber. So somehow MRCP did not pick up. But probably over time, MRCP for a little older. Otherwise, IOC is better. Suppose you suspect a biliary atresia, doctor, best is to open the abdomen, take the biopsy and do an intraoperative cholangiogram, which will give you a better delineation. Because these tubes are so thin. Just because you're able to see an MRCP, suppose by chance you're not able to see and then you open and then you get the duct, it won't be good. So suppose there is a doubt. We have got very good pediatric surgeons who do a very small mini lab, straight away see the GB, inject the dye, they have a good arm, C-arm, show you an IUC and come out. It's so neat. I think for the time, what do you say, Nirmala?
Yes, madam, that is better. And in case you want to operate straight away, you can operate.
The MRCP, it looks sounds very nice, non-invasive, but the pictures are not good for that age, doctor, and so much of movement artifacts are there.
Okay, madam. Thank you. Sir, Arun, sir.
Yeah, I think the session was wonderful. And all the Professor Malati, madam, and the two professors from ICH, Dr. Nirmala and Dr. Sumati from Stanley, they were all very cordial with the students, and they almost took them by holding their hand and taking them through the journey. It was nice.
And I think we should thank you, Doctor, for that patient listening to all our talk and trying to put them. I think that's how they brought us up. Our teachers brought us up to this level. I think we should also train them and bring them up. I think they are getting good training.
You have to give them back. You have to give
Yes.
them back.
Thank you for
Thank you
this
so much for the
opportunity.
innovative concept, and thank you for the opportunity also. We are very
Thank
happy.
you so much, madam. Thank you. It was a nice session. Thank you all for your
Thank you.
wonderful
So on behalf
Thank you
of,
so much.
yeah, on behalf of IAP TNSC, I thank Madam Maladi Madam, I think teachers of teacher, and I thank you, Madam, and I thank Dr. Nimla Madam. I usually she won't accept this kind of meeting. I think
I'm not very comfortable with Zoom.
Yeah,
That's why you came through our director.
yeah. So I think nice, Madam. I think it's a great opportunity to see you.
Yes,
Also. I think it's more than 1,000 students all over India they're watching.
yes.
I think it's a good platform for us also to see you. And thank you, madam. And thank you, Dr. Smati, madam. I think she helped a lot to learn our students. And I think excellent presentation by both students, Arun Jiva.
We have to appreciate the students for them.
Yeah, Raj Kamal. Yeah, and I think initial kick up, but they finished very well. Okay, it's a great opportunity for all of us also. Thank one and all. Thank you.
Thank you.
Thank you. Thank you, Nirmala. Thank you so
Thank you,
much.
sir. Thank you, madam.
Thank you so much.
Thank you,
Bye,
madam.
ma.
Bye. Bye, Sumati.
Bye.
Thank you, sir.